Hello everybody, this is Dr. Kachikian from the Black Hills Regional Eye Institute, and this is just a routine case that we did a week or so ago. We're just getting the eye lined up. I'm looking to put a 1 millimeter side port in, and the patient's kind of looking superiorly, so I want to get him to look down so that I can place that side port appropriately. You want to make sure that that incision is parallel to the iris. If it's angled down, it does have a tendency to leak some more. This is preservative-free lidocaine, and then we will place our viscoelastic and try and get a nice viscoelastic kind of wave across the eye to get a good fill. And the visco does still have those silicone bubbles there. They're somewhat annoying, but really inconsequential. Try and get the eye to be centered. Put a little 5 millimeter mark on the surface of the eye just as a guide for the capsulorhexis. I use a Thornton ring. I keep the spikes up so that we don't have any subconjunctival hemorrhages. And then I make a single plane incision, being really careful how I angle the blade to create an internal wound that is parallel to the external wound and doesn't have any of the chevron sign. We start our capsulorhexis with the Utrata, and sometimes I'll try and follow that 5 millimeter mark that I made. Other times I'll just use it as a size guide and follow the edge of the iris. I do tend to make a larger capsulorhexis in general, but try to keep it so that the edge of the capsulorhexis overlaps the optic for 360 degrees. So we will complete our capsulorhexis, trying to finish the capsulorhexis outside of where you started, and then we will do our hydrodissection. I use a 27 gauge cannula for hydrodissection and get a good fluid wave, push down on the lens, change to the other side, again, good fluid wave there, push down the lens and rotate. And then we'll do a hydrodelineation. I always try and get good hydrodelineation and really good rotation. We'll place, there you can see the incision. It's a good incision, parallel internal and external wounds. A little more viscoat in the anterior chamber, then we will start, we'll check our flow, and then usually I begin in quadrant removal mode to clear out any viscoelastic so that the tip of the phaco is not clogged, so that it is open. And I also clear out the anterior cortex and epinucleus. Then we start sculpting. This is kind of, I'd say, denser than average lens. When I do have these dense lenses, I tend to sculpt deeply centrally, and I try and minimize the amount of energy I use by sculpting in the periphery. I just try and get a deep central groove. So we've got our halves made, and then this is just a nice lens. It cracks very easily. Those are some horizontal chops in order to break the lens up into thirds for that heminucleus, and then we'll do kind of a vertical chop here. There you go, and now we've got about 6 pieces, keeping both the second instrument and the phaco handpiece fairly central, and we will emulsify each one of those pieces one by one, kind of carouseling around and just removing each piece of the lens. The pieces come to the tip pretty easily. It's just the consistency of the lens is really kind of lends itself to this particular phaco pattern. This piece is a little bit bigger. We'll take it out in 2 separate chunks, and we use a second instrument to try and dismantle a little further. Now we've got our epinucleus, and usually again I'll remove epinucleus just on quadrant removal mode, getting some good aspiration rate going and taking out the epinucleus one by one. Sometimes you have to rotate it a little bit if it doesn't kind of fold over on itself. Sometimes when it does fold over on itself, it gets stuck in the viscoelastic, so that's not ideal. So just take it as it comes. Now we've got the nucleus and epinucleus removed, and now we will change over to INA in an attempt to remove the cortex. You can see in this picture the patient does have kind of a big floater in the back as well. All right, get that cortical material out of there, and I just, again, with the cortex, I'll kind of take whatever comes. Sometimes I'll go around 360 degrees, sometimes I'll go section by section. try and go tangentially and then centrally. Gotta be careful here, subincisional cortex. You want to try to not grab the capsular bag if possible, and just get those cortical pieces out of there. So now all our cortex is out. Now that we've got the cortical material out of there, I do use BSS and kind of power wash the capsule. I use streams of BSS a few times throughout the case, usually to remove any cortical strands that are on the posterior capsule. Sometimes I will use it to see if there's any residual cortex in the fornix of the capsular bag, because that sometimes is hard to visualize. And I also use to check at the end of the case for any pieces or nuclear fragments that may be left in the angle of the anterior chamber. We fill the capsular bag with Provisc, and then I will usually do some capsular polishing, try and remove just as many of those anterior lens capsule cells that come off easily. You could polish for a very long time to get all of those cells off, but I try and just remove the bulk of the material, and then we will place our lens. I usually stabilize the eye with the second instrument, and then this is the Alcon Autonomy injector with a Clarion lens. I'm going into the capsular bag, and I'll usually always use a second instrument for positioning, because I like to have the lens placed just as I want it, and I don't really feel like the IA sometimes gives me as much control as I would like. Once the lens is in place in the capsular bag, we'll go behind the lens with the IA, get out all of the viscoelastic that is behind the lens, take out those little anterior capsular pieces that came from the polishing, and then go around 360 degrees and try and get the angle on each side, as well as the center viscote or viscoelastic that is coming right from the kind of the apex of the cornea there. So now we've got all our viscoelastic out, as much as we can see at least. We'll center the lens, and we'll use some BSS to reinflate the anterior chamber, seal up our incisions, and check for any residual viscoelastic that might be hiding the angle. So here we go, checking for viscoelastic. You may see that there's some kind of pieces of visco that just kind of are liberated from the angle. I don't know how consequential those are for IOP, probably not very, because it's a small amount of viscoelastic, but it's nice to get it out when you can. We'll continue hydrating our incisions. Also place a little bit of moxifloxacin, intracameral antibiotic. We'll check our pressure and check with WEC, and the case is complete. All right, I hope you folks enjoyed that. This is Dr. K from the Black Hills Regional Eye Institute. Have a great day.